Yeah, I'm recording right now, so you're fine. But yes, it's going to be cold all day. I need to get to the chat. Hello, my name is Dominique Gallo, and I'm an international board certified lactation consultant here in the Roanoke area, and I will be presenting to you guys today navigating the NICU, what new parents can expect when dealing with the unexpected. So this is me and my family. Again, I'm an international board certified lactation consultant. I'm the owner and operator of Gallo Birth Services here in the Roanoke area. I am not native to Roanoke. I've only been here for about 5 years. I am from Newport News, Virginia. And we moved here when my oldest, before she started school, because we felt that the schools were a little bit better here. And we just were looking for just a new place to be and experience in Virginia. I have 9 years of experience with educating families and professionals on breastfeeding and helping families meet their breastfeeding goals. And I've nursed all of my children for a combined of 6.8 years. And I've nursed through a pregnancy as well, because one of my babies just could not give up the dream. So here, and with my private practice, I do offer online breastfeeding education in the form of Breastfeeding 101, and I do several other classes like going back to work, infant nutrition, and exclusive pumping, how to get started with that. I do virtual consultations as well as in-home consultations. And you can visit all of these services in my website if you're interested, and I'll give that to you at the end of the presentation. So objectives, right? You want to know what you're going to learn in this presentation. So first, we're going to understand the behaviors of premature infants. We're going to learn NICU protocols and procedures, and we're going to increase our knowledge about human milk feeding and its importance in the NICU. So childbirth and being pregnant has so many unknowns. You prepare for your childbirth experience by taking classes. You prepare for the pregnancy by going to your appointments and meeting with your OB or your midwife. But sometimes things happen, things change, the plans change. And so you may go into labor early, or you may have some complications that may make you have to deliver your baby early. And so with this presentation, my hope is to help you navigate that if for some odd reason that is what will happen to you. So we're going to understand how to navigate the unknowns and kind of prepare you a little bit so that you know how to best support your baby once they arrive. So first, what the heck even is a NICU? So NICU stands for Neonatal Intensive Care Unit. It is a special wing of the hospital for vulnerable babies that are born early or very sick, to get specialized care. A premature infant. So the March of Dimes defines a premature infant, or a preemie, as any baby born before 37 weeks gestation. And this is further broken down by weeks, because the earlier the baby is, the more complications that they may have. And so understanding how early the baby is will help the care team to better prepare for what to expect with the baby. So a late preterm infant, and in the lactation world, we call these babies the great pretenders because they're born, they look full term. Sometimes they may act full term in their behavior when they're first born, but they do have a lot of preemie tendencies, and we'll talk about that. So a late preterm infant is a baby born between 34 and 37 weeks. A moderate preterm baby is any baby born between 32 and 34 weeks. And a very preterm baby is any baby born before 34 weeks. These babies are at greater risk for infection and other health issues that may affect their brain, lungs, hearts, and eyes. So why do premature infants need the NICU? So again, babies born early can lead to a host of complications because the baby no longer has that protection of mother's immune system. They know they have to do things on their own that their body may not be fully prepared for, so the placenta kind of helped them with that. And they don't have that protection of that amniotic fluid to keep their environment stale. So some infections that may happen in the NICU with premature babies, not to say that all of these will happen to your baby or any of them. However, these are some things that can happen, and the younger or earlier your baby is, that increases their risk. So some babies may develop apnea of prematurity, which or AOP. And this is pauses in breathing for 15 to 20 seconds or more. Bronchial pulmonary dysplasia, or BPD, which is a lung disease that develops in preemies. It puts them at higher risk for lung infections later in life and lung damage. Respiratory distress syndrome, or RDS, where the lungs do not make enough surfactant. Surfactant is important because it keeps the lungs from collapsing. Intraventricular hemorrhage, or IVH, which is bleeding in the fluid-filled spaces in the brain. Jaundice, which is when a liver that is not quite mature enough or working properly cannot break down the elevated amounts of bilirubin in the blood. A very big and important one is necrotitis enterocolitis, or NEC, or NEC. Is a very serious disease, very common in the NICU, affects a baby's intestines and can cause them to become infected. Another issue can be the patent ductus arteriosus, and I'm sorry if I'm pronouncing these incorrectly, or PDA, which is a heart condition that happens when the blood vessels, particularly the ductus arteriosus, does not close properly after delivery. And then renopathy of prematurity, or ROP, ROP, is an eye disease that happens when the retinas do not develop further after birth. So again, these are not something that happens, you know, to all premature babies, but these are just some of the issues that the care team are watching out for, because again, the younger the baby, the earlier the baby, they have increased risk of some of these things. And so these are why the baby needs a specialized unit, so that they have a team that is trained to know how to handle these complications, can do that as quickly as possible and effectively. So, preemie behavior. Why is my baby acting like this? Full-term babies are good at regulating their body temperatures and their blood sugars, and they can tell you when they're hungry and they can tell you when they're not hungry. They wake up on their own. They don't need a lot of assistance. Premature babies need a lot of help with these things, because these are things that they learn when they're inside of the body so that they can do them in real time when they're born. But when they're born early, they lose their practice. And sometimes when you're trying to perform something without practice, you don't do it very well. And so again, the NICU has interventions that they can do to help baby to maintain these things while they're learning how to do it on their own. So the biggest one is preemies get tired easily. They don't have a lot of reserves. The earlier the baby the more likely they don't have a lot of energy to do basic skills. So when we talk about feeding babies and interacting with them, we really want to think about their energy expenditure. How much energy do they have to give to this task? If they do not have a lot of energy to give to the task, then they will shut down, they'll go to sleep, and it's really hard to get them to come back and finish what we're trying to get them to do. So you may notice that in the NICU, the staff may try to consolidate a lot of things, get several things done in a small amount of time, because that may just be all the window that they have to make sure that the baby can participate and do those things. Preemies sometimes are poor feeders and require assistance and intervention to be fed. Again, it's all energy expenditure. Do they have a lot of energy to go to the breast and nurse for 30 minutes? A lot of times, no. So sometimes they'll need help via feeding tubes. Sometimes they'll have to be bottle fed because the bottle is a lot easier than the breast, and they don't have to waste a ton of energy in order to do that. Depending on how early your baby is, they may not cry as much or demand to eat. If they do cry, the cry may be soft and short in duration. And again, they tend to be very sleepy and sometimes very hard to wake. So again, they're not cueing that they need to be fed. And if they are, sometimes it can be missed because they, again, energy expenditure. They don't have a lot of energy to tell you that they're hungry. So if they do try, they may not try for very long. And medically, they may have low temperatures, low blood sugars, or low blood glucose, and they are at risk for breathing difficulties and jaundice. So how do we support these behaviors in the NICU setting? Again, since premature babies tend to be more sleepier in the NICU, the NICUs tend to have them on a 3-hour feeding schedule. And I know you're saying, I want to breastfeed my baby. I was told to breastfeed on demand. If we're on a schedule, how will that affect my supply? And again, I know this seems counterproductive for breastfeeding, but again, we have to think of energy expenditure. You know, the baby may not have a lot of energy to sit on the breast every hour, every 2 hours. Every 3 hours, make sure that baby gets enough sleep so that they can gain enough energy for the feed without going too long between feeds. The baby may be placed inside of an isolette to help the baby maintain normal body temperature. And I have a picture of one later, and the slide I had before had a picture of a baby in isolette, but usually it's just it's a clear box essentially where staff can adjust the temperature. So as your baby is able to control their temperature better, they'll lower the temperature inside of the isolette until the baby is able to do it on their own. The infant may also have what we call blood sugar, but essentially it's low blood glucose levels. And this is important because the brain needs the blood glucose in order to function, as well as other stuff, but the brain is important. So if there's not a lot of blood sugar in the baby's system or blood glucose, this could really affect the baby's brain. So that's why they're always checking it and watching for symptoms of when the baby has low blood sugar. And so the picture that is here is a baby getting their blood sugar checked. It's usually a heel prick. They'll take a teeny drop of blood, it'll go into a machine and it'll read the levels, and depending on how early your baby is, will determine if that baby's levels, the number that gets kicked back is within a normal range. So your baby's blood, when babies are born early, typically they check the blood glucose right away just because they're born early. And then as the baby is symptomatic, they will check it again. If the baby has really low blood glucose levels, and again, it's going to be a low range for their age and gestational life, or gestational age, excuse me. If it's too low and they try an intervention and it still does not come up to a normal range for their gestational age, then staff may use IV fluids, which has glucose in it, to feed the baby a steady stream of glucose until the baby is able to maintain a certain number, again, based on their gestational age, on their own. And staff will check blood sugar depending on what the neonatologist or the pediatrician suggests, and they'll wean off the fluids, again, as baby is able to do it on their own. Bilirubin levels are checked to determine if the infant has jaundice. They can do I know here it says blood, but they can also do a skin test as well. And if that is really high, then they'll check the blood. But as your baby, again, shows symptoms, they will do these tests. And if the levels are too high, baby will be placed under a special light, which a Billy light, so it's a blue light, and sometimes they'll even use a Billy blanket that the baby will lay on top of to help the baby's body to break up this extra bilirubin and pass it. Care time in the NICU. So NICUs sometimes do not have spaces for parents to room in with their infants. So most NICUs have what is called care time. And these are predetermined times that parents can come to the NICU to do baby care. This includes feedings, diaper changes, taking care of the baby's space, doing skin to skin. When you, if for some odd reason you have a baby in the NICU, find out when these care times are and try to be there for those care times as much as possible. Your baby really enjoys being around you. You know, they know you, they know your voice, and it really makes them feel better when you are around. And you know, the staff isn't mean to them, but, you know, they like their parents, not staff. So as much as you can participate in these care times, I would strongly recommend that you do. The babies respond a lot better when they're being taken care of by their parents. Again, these times vary depending on the NICU. I know RMH is one that which is our local NICU, is one that does have care times. So if your baby has to be admitted into the NICU, make sure you ask about the care times. And again, attend as many care times as possible. The more close interaction you have with the baby, the better. So now we're going to move on to talking about how human milk is important with premature babies and helping to protect them from some of those illnesses that they can get while in the NICU or just being born a little bit early. So first, let's talk about how breast milk production works. So breast milk, or colostrum as we know it, that first milk is produced while mom is pregnant. Sometimes moms will see that they may leak a clear fluid. Sometimes they'll say, oh, my breast got really tender during this one time, or maybe the entire pregnancy. They may notice that their breast may grow a size or two during pregnancy. This is all preparation for colostrum, and that leaking is the actual colostrum. Not all moms participate in the leaking, but some do, but that's just further evidence that that colostrum is being made. And it's made during pregnancy, so when the baby is born, the baby has something to eat until the hormone exchanges happen and that mature milk comes in over the next 2 to 3 days. So after the delivery of the placenta, this lowers the estrogen levels, which then triggers the body to increase prolactin levels. And I know this is a bunch of big words, but this is pretty much how the process works simplified. That placenta comes out, that triggers the body to start releasing the hormones that are needed for breast milk production. And then once those hormones get to a certain level, that's when the mature milk production will begin. And you'll notice there'll be a transition. So you'll have colostrum, and then you'll start making large amounts of milk, which is still yellow. And a lot of people think that, oh, I'm making, ounces of colostrum, but really this is called transitional milk. It's that mature milk coming in and that colostrum moving out. And then after after about a day or so of transitional milk, then you'll notice that your milk will get that more traditional white color that we're used to seeing, and that is the mature milk. So frequent nursing breast stimulation via the pump helps to get those prolactin levels to increase quickly. However, understand that if you do nothing, this will not stop the process of the full milk from coming, because in the beginning it's hormonal. Remember, we talked about when that placenta leaves, then that triggers the prolactin to start. But frequent nursing and breast stimulation does help the process move along faster. So if you do nothing, full milk will come in, but you won't have as much of it, and it will take a lot longer for the process to happen. And parents that do not have underlying medical conditions, so parents or mothers that don't have underlying medical conditions, nursing and pumping early and often will help to ensure that your mature milk production comes in when it's supposed to, and you'll have an abundance of supply. So there are some feeding options that can happen in the NICU. They may be fed via breast, feeding tube, bottle, finger feeding, cup feeding, and supplemental nursing system, or S&S. Infants less than 34 weeks gestation will take feeds via feeding tube. Again, it's energy expenditure, and also too, they have not been in the uterus long enough to get that suck, swallow, breathe coordination down. So they will be doing feeds via the feeding tube. And then when they are able to take feeds orally, then it will be via bottle, breastfeeding, finger feeding, or cup feeding, or using that S&S. The bottle is the most common way to feed a baby in the NICU. Again, energy expenditure, it's a lot easier. Cup feeding and finger feeding are the least common ways to feed the baby in the NICU, again, because of energy expenditure for the infant and the time it takes for staff to feed babies in this way. So not saying that it cannot happen. However, it's not a common way to have your baby fed in the NICU, because they want to make sure that anything that's done to the baby is consolidated, so they have a longer time to rest and build up energy to handle the feeds and work on the feeds that they're doing. So human milk is medicine to preemies in the NICU. It has lots of antibodies and antivirals to help to produce, to build up that immune system. It protects their gut and keeps their healthy bacteria and their microbiome plentiful, so that they can ward off infection. So human milk is easily digested by the baby, so you don't have to worry about them having any major intolerances, because this milk was made for them. It's made for humans. It also contains the best source of nutrients and fats to help your baby grow and develop. One of the big things in breast milk is the Hamlet cell, which helps to fight cancer. And human milk also has the SIG-A antibody, which helps to shape the baby's immune system. And these are really important. Also, a good side note is that the Hamlet protein, I think it's Sweden, actually uses this to help some of their patients that have bladder cancer. And it's been shown to work pretty well, I think. So your breast milk is medicine for the baby, and it's important that babies get the human milk, as much of it as possible. So how do we support human milk feeding in the NICU? The big thing is to ask for skin-to-skin or kangaroo mother care right away, as soon as your baby is clinically stable and able to do so. Skin-to-skin reduces baby's mortality, reduces illness, reduces infection. It shortens their length of hospital stay. It increases the bonding, and it helps to get breastfeeding initiation going. And it also helps mother with her milk supply. Skin to skin also helps to stabilize vitals like their temperatures, their heart rate, and their breathing, which are things that are constantly being monitored with premature babies. Infants younger than 34 weeks, again, do not take feeds by mouth. However, it's important, again, that mother is pumping. And so sometimes they will get the colostrum and they will swab mama's, they'll swab baby's mouth to make sure that they can get that colostrum. Infants older than 34 weeks can try oral feeds. I always suggest moms to use a supplemental nursing system because sometimes these babies do need to be supplemented, and what better way to do that than at the breast? They can get their whole feeding at the breast. So if the staff can conjure you up one, or if you can buy one, SNSs are really great to help support that baby feed at the breast. Again, you can try finger feeding and cup feeding for supplementation, but just keep in mind the level of exhaustion that these feeding methods may cause for your baby. So just talk to staff and see if that's something reasonable for your baby to do in the NICU setting. If your baby has to be bottle fed after nursing, try not to feel defeated. We don't want to wear your baby out because they won't have enough energy to keep up trying to learn how to breastfeed. If you do have to use a bottle, make sure it's a slow flow nipple or a nipple appropriate for your baby's energy levels, and make sure you are practicing paced bottle feeding. This will slow the feed down some, make the baby work a little bit, but not too much, so that they have those same expectations when they go to the breast. Also, make sure that you ask to work with an IBCLC. An IBCLC, again, is an international board certified lactation consultant. They have the highest level of lactation certification. Their training includes 1,000 hours of clinical lactation skills, and they have to have that before they can even take the test to become a lactation consultant. They also have to have 90 hours of lactation specific education, as well as several college level courses. And they're also specifically trained and educated in dealing with clinical management of human milk feeding. So especially in the NICU setting, they can give you a feeding plan that best supports your baby's feeding needs. Again, energy expenditure. And once the baby has graduated from the NICU, it's also suggested that you work with the IBCLC outpatient to the babies at least to their due date, or 2 to 3 weeks after leaving the NICU, to make sure that your baby is able to maintain good feeding, especially at the breast, and maintaining good growth patterns once they leave the NICU. So make sure that you are pumping. The Affordable Care Act, or ACA, mandates that insurances must cover a double electric breast pump for pregnant parents that are choosing to provide human milk to their babies. So call your insurance company or talk to your lactation consultant or your OB or midwife to see how you can get a breast pump if you have not already ordered it. And my best advice is to call and see when they will send it to you. Some insurances, all you need is a positive pregnancy test, but some want you to be a little bit further along. Call, find out what that is, and order your pump, because if something happens, the unknown happens, like we talked about earlier, and your baby has to be delivered early, or you go into premature labor, you want to make sure that you have that pump on board. So call and see when you can get your breast pump, and if they say you can get it at XYZ time, go ahead and order that breast pump. If you can't get your breast pump in time, or by the time your baby is born, check with your local hospitals and see if you can rent one. I know personally at Louisville, they do have They do have breast pump rentals, and they also do at RMH. So you can get with the lactation consultants there and find out how much it costs to rent a breast pump, what kind of pumps they have to rent, and how long that you can rent that breast pump for. If you qualify for the WIC program, or Women, Infants, Children, they have the same breast pumps that both hospitals rent out, but it is free for you to use if you are on that program until you can get your pump in the mail. So if you qualify for WIC and you're actively on the program while you're pregnant, reach out to the peer counselor or the peer counselor coordinator. I'm someone on my words. But reach out to them and see about renting a breast pump. Let them know that your baby is in the NICU, or you may have to deliver early, so that you can have those things in place until you get your pump through the mail. Also, too, I can't say this enough, watch lots of videos on hand expression. Hand expressing is a very good way to get colostrum out of you, and it's very good stimulus to help to bring in your full milk faster. I often tell parents, yes, use that breast pump because it's a good way to get some really good stimulation in very quickly. But every other feed, do some hand expressing so you can really remove that colostrum and get that process going. And that's a really good option as well until you get your full milk in too. So learn some hand expressing. My favorite one is the Stanford hand expression video. That's how I learned how to do hand expressing. Once you get it down pat, it's fairly easy to do. Once you have your baby, start pumping early and often. Try to pump at least 1 to 2 hours after delivery or when the separation starts. So if your baby is born and the baby is really early and they know this baby has to go to NICU right away, start pumping as soon, no later than an hour or two after that happens. Or if your baby was fine and then all of a sudden not fine and has to go to NICU, you start pumping within an hour or two once that separation starts. Try to pump at least 8 times in 24 hours minimally. Obviously, the more you can do, the better. If your baby is admitted into the NICU, try to pump bedside as much as possible. The way your baby smells, seeing your baby, touching your baby, all of those things help to produce breast milk for your baby and get those hormones going. Talk to the lactation consultant. Make sure that your flanges are a proper size for your pump. Make sure that the pumping is comfortable. If the flanges aren't a good size, or if the pumping hurts, you are not going to be stimulating yourself properly. You're not going to have good milk production or output. And make sure that you understand the breast milk storage guidelines in general, and also the guidelines for the NICU, because those are going to be different than the general guidelines that we send parents home when they have full-term healthy babies. And also, again, and parents that don't have any underlying medical issues, the more you pump, the more you make. There's no magic pill. I know a lot of people say, oh, if you take this supplement, or if you drink this juice, or you drink this Gatorade, drink this water, there is nothing magical that you can purchase that will do more than breast stimulation. Our breasts expect us to empty them frequently so that they know to make more milk. And that is what should be the main thing you're doing. If you want to try any of these supplementations or drink, please talk to the lactation consultant that's working with your baby in the NICU before you take any of that stuff, because some of those things are contraindicated for babies that are in the NICU setting. So for mothers that are not producing enough breast milk yet, babies that are born 32 weeks or younger over at our hospital here, Roanoke Memorial, the milk donated, they will get donor milk, and donor milk is milk that is donated by other lactating parents that underwent specific testing, screening in order for their breast milk to go to the milk bank. The milk bank does a process called pooling, where they take several different mothers' milk and they pour it in one container, because that way the baby gets exposed to lots of different varieties of antibodies, which is really good when you have a baby in the NICU that is prone for infection. So they do pooling, and then they'll pasteurize and homogenize this milk, and then they sell it to various hospitals that's in their area, so that those babies can be fed that donor milk. And so at RMH, the babies that are 32 weeks or younger will have the ability to get donor milk. Roanoke Memorial Hospital gets their milk from, near my hometown, Children's Hospital of King's Daughter in Norfolk, Virginia. And if you are looking to donate breast milk to them, just go to their website and contact them, or you can email me and we can go over the process in order for that to happen. Roanoke Memorial Hospital does allow for mother-to-mother donated milk on their unit, but you must sign an agreement in order to use it, just so that you know the risk of doing this. And mother-to-mother donated milk is, again, it is breast milk that is pumped by other lactating parents, but instead of going through the screening process and the pasteurization and all of that stuff, it is directly pumped from the parent and given to the parent that is needing it. So sometimes we have sisters or best friends that are also lactating and they're willing to share the milk, and that is fine. But talk to the lactation consultant before you start that process, just to make sure if that is the right thing to do for your baby. Also, too, for moms that are producing enough, you may notice that they may want to fortify your breast milk. And what that means is that they just want to add a substance to the breast milk that helps to boost the proteins and the fats and the calories, because we want your babies to grow not super fast, but we want them to maintain a steady growth, because they do burn a lot of energy and calories trying to maintain life outside of the womb. So babies that are younger than 32 weeks gestation, they'll use Prolacta, and that is a human milk fortifier that is made from human milk. After 32 weeks, they'll use what is called HMF, or human milk fortifier, but that is cow milk based. You can choose, and also too, you can also choose to just supplement with formula. So kind of doing half and half. So giving your baby some breast milk, but also following up with formula, specialized formula that is for younger babies, to make sure that your baby is getting that boost and those proteins, fats, and calories. I would say, though, if you have enough breast milk for your baby, go with those fortifiers, because we really want your baby to get as much of your milk as possible, even if it has to have a fortifier in it. So, in conclusion, my tips for you guys are to try not to be intimidated by the NICU setting. Yes, there's a lot of machines and noises and goings-ons, and your baby is so tiny, but just focus on your baby and make sure that they know that you are there. Just like you, those babies are nervous, they're worried, they're scared, they have no idea what's going on, but they'll feel much better if you are there and beside them and touching them and talking to them. So focus on the baby, don't focus on all the hubbub that's going on around. Some premature babies do really well very quickly, and some need a little bit more time. So be patient with the process and trust your baby's care team, but also ask a ton of questions if you're not sure about what's going on. Be patient with them, provide the extra care and attention that they need when they need it. Going with the flow with the baby helps them to leave the NICU a little bit faster. And again, understand that there's no magic pill or drink for milk production. Under normal circumstances, again, the breast is stimulated when and to make breast milk when you do that. So make sure you're pumping regularly and hand expressing and putting baby to breast and doing skin to skin as much as possible. And again, work with that IBCLC to make sure you have a good quality pump, that you're using your settings on that pump correctly, that your flanges are a good fit. That way you can maximize your milk production. Try not to feel defeated or worried if baby does not or cannot finish whole feeds at the breast. Baby will get there in time. Practice makes perfect. Sometimes there's other things that those little bodies have to focus on in the moment, but keep trying. And again, ask for as much skin to skin as possible and participate in as much care time as possible. The NICU staff is there to help you. They are not there to deter you from your goals with your baby. Do not feel like you cannot ask them questions. You are not taking up their time. Your questions are super important because they involve the care of your baby. So make sure that you ask questions, ask a lot of questions, even if you feel like they are dumb questions. Ask those questions. So that is the end of my presentation. Again, my name is Dominique Gallo. I'm an international board certified lactation consultant here in the Roanoke area. There is my email, dominique@dominiquedoula.com, and at my website is www.dominiquedoula.com. If you have questions about anything I said in this presentation or need me to clarify anything, or just questions in general, please email me. Thank you for attending my webinar here, and Huddle Up Moms, thank you for allowing me to participate in this wonderful event. So I think I am done. Let me open the chat.
All I have to do is get my water.
Okay, well, let's do that.
I washed my lunchbox. I got all my snacks, and they were all in bags. And